Welcome. I'm Danielle Wynn. I'm a veterinarian. I am also an acupuncturist. I'm certified in veterinary pain management, and I'm also certified in canine rehabilitation. This presentation is about veterinary rehabilitation and how it can help your patient or pet. So, this is our team. Our team is made up of veterinarians, physical therapists, and veterinary physiotherapists. We have Dr. Allison Cotter on our team. She's a veterinarian. She's rehab certified and acupuncture certified. Dr. Erica Kirsch is a physical therapist that is rehab certified. She also has additional certification in musculoskeletal ultrasound. Dr. Rebecca Hall was an ER doctor for 16 years, and now she's on the rehab side. So she is rehab certified and acupuncture certified. Dr. Cassie has an interesting background. She's a physical therapist that worked at a human neurophysiology department, helping paralyzed people learn how to walk again. And in the last couple of years, she has transitioned over to the veterinary side and she's applying her skills to animals and helping them learn how to walk again. Carrie is a veterinary physiotherapist. She comes to us from the UK. Phoebe is our massage therapist, and Andrea is a veterinary technician. So, our team is made up of veterinarians and physical therapists and veterinary physiotherapists. And it's really nice because we all have different skill sets that we bring to the table. Often we will work with a physical therapist on how to, you know, how do we translate what you would do in humans to a dog? So, for instance, we may have an injury that we have a lot of knowledge about on the human side, but not a lot of standards already created on the veterinary side. So, we will work with the veterinary physical therapist on okay, in a human, how would you get this human walking again or using this limb again? And then we'll go ahead and create exercises that mimic those movements. So this is our practice. When I started the practice, I started off just doing home visits and I quickly outgrew home visits. So then I needed a location. I subleased out of Orthopets for a little bit while our practice was being built in central Boulder. So I would see patients half the week, and then the other half of the week, they would manufacture the devices that my patients were going into. So I got a lot of experience in veterinary orthotics and prosthetics and the manufacturing side and performing adjustments. We have been in our location in Central Boulder for the last couple of years, and our team has grown since entering, and our practice has grown hugely. When I built the practice, it was very important to me that we have a practice that's very calming and spa-like. Our patients come in to the very first appointment. Often they're stressed, they're in pain. The clients are anxious about what's going on with their pet. So creating a calming environment was very important to us. Our rooms, we see our patients on the floor, so we don't place them up on a table. And it's really cool to see by the end of our sessions how we have some patients that come in that are highly aggressive. Typically, at the general practice, they would be muzzled. By the end of our session, they're on the ground, sleeping on the bed, and they're receiving acupuncture or whatever treatments that they need that day. Our lights dim in the room, and we have spa music playing in the background. This is our exercise area. We have every possible equipment in the rehab field. We have a lane treadmill, we have a vibration plate that we utilize in our patients. We even have the underwater treadmill. The underwater treadmill we may fill up and we have jets so patients can go ahead and swim against the current too if we didn't want them to walk in the underwater treadmill. So, what is rehabilitation? Rehabilitation is the treatment of disease, injury, or deformity using techniques that promote the ability to move, reduce pain, restore function, and prevent disability. Reducing pain is a big one for me, just being a certified veterinary pain practitioner. For so long, I think we only saw patients about 8 to 10 weeks after surgery because there was this misconception in our field that physical therapy was just strength building. But that's actually far from the case. We're very much focused on pain management first, swelling reduction, improving mobility of the tissues, improving weight bearing, and strength building is actually one of the very last things that we approach. The cases that we essentially see any patient that has difficulty with mobility, moving, or maneuvering in their day to day activities. So if you have a patient that comes into your practice and the clients are complaining that, their dog's getting weak, or they're struggling to maneuver up and down the stairs, in and out of the house, or they used to have an activity that they can no longer do, such as going on long walks or going hiking with them or biking or running. Those are patients that you can go ahead and send our way. Anytime you see a patient with a limp or any type of lameness, or any neurologic condition, that's right up our alley. We see patients pre-op, so we may be focusing on pain reduction, swelling reduction, improving weight bearing, building up muscle mass before they go into surgery. That way they have a quicker and smoother recovery. We will see patients about 3 to 4 days post-op, in which we're focusing on pain management, swelling reduction, improving mobility of the tissue, and then slowly weight bearing and strength building. And then we have the cases that are no op. So they're either not going to go forth with surgery due to their own personal beliefs or finances, or the patient is just not a surgical or anesthetic candidate. So we have to have a solution for those patients. So they will often get bounced our way. Whoops, let me back up. We will see neurologic, orthopedic, and soft tissue injuries are pretty much the main types of cases that we see. So, common conditions that we treat. Here's a list of some of the conditions that we treat, and I'll go ahead and branch a little deeper into each one of these injuries. Carpal hyperextension injuries are very common at our practice: CCL tears, patellar luxations, Achilles, LS disease. So, we do have a lot of German Shepherds coming through our practice with LS disease. General arthritis, whether it be elbow or hip arthritis or tarsal, is common. IVDD or any type of myelopathy is common in our practice. Brachial plexus injuries, amputations, obesities, wobbler disease, vestibular disease, DM, and limb weakness. Vestibular disease is an interesting one because we don't have a lot of standards in veterinary medicine on how you take a patient with vestibular disease and get them balanced again. So, with that, we work with a physical therapist and have done a lot of research on the human side with a human with vestibular disease and what exercises they do. So, with those patients, a lot of them will do focusing exercises where they have to focus on a treat while we're moving the head side to side, up and down, and then we have to have them focus on a treat while the treat is moving back and forth. We'll even do blindfold exercises on dogs where we take the visual input away and then we have them focus on their balance. And it works. It's really cool. Over the years, I've seen a lot of vestibular disease dogs improve when we apply these techniques that they do on humans to a dog. DM, even though we don't have a cure for DM, we do delay progression. We keep those patients walking longer with regular physical therapy. So, carpal hyperextension injuries, we see them either acute or chronic. So, this is an example. This is Indy. Indy would go mountain biking with his dad, and one day he jumped off of a boulder, and then the wrist dropped down to the ground. Dad was not going to go forth with surgery, so we have to have a solution if a owner is not going to go forth with surgery on what can we do. So anyway, we went ahead and put in a carpal orthotic and started strength building on building up all his carpal flexors to counter that carpal hyperextension, and then help allow scar tissue to build up on the dorsal side of the wrist to stabilize that wrist. Our carpal hyperextension injuries, it's a very common one in Colorado just because we are a very athletic area. So we have a lot of dogs going out hiking, running, jumping. So they're more prone to carpal hyperextension injuries here. We also see the chronic cases where dog is weight shifting forward and that wrist is starting to drop down to the ground. So we want to build up those carpal flexors to go ahead and counter that. So this brace on the left, this black brace, Indy progressed from a caudal shell to a cranial shell. So as his wrist started to stabilize, we went ahead and transitioned him to a new device. And Indy has since graduated from rehab. Here's another example of a carpal orthotic for carpal hyperextension injury on the right. Brachial plexus injuries, we do see a couple times a year. You know, with your brachial plexus injuries, the nerves regenerate about a millimeter a day. So I would say give those cases at least a month to see if that limb is going to go ahead and regenerate its nerves and become functional before we decide to amputate. I've seen everything. I've seen the patients where we went forth and amputated because we weren't bringing back any function to the leg. I've had the cases where we were able to get a brachial plexus completely healed back up to running and jumping again. This case is a dog that, was hit by a car, and this, after a couple months of rehab at another center, was then transferred to us. And obviously, he cannot extend his carpus. He can't fully extend his elbow to go ahead and weight bear on that leg. Mom was not going to go forth with surgery to amputate the leg. So we have to have some solution for the dog. And our solution was a carpal orthotic that we then went ahead and performed physical therapy with. So this is the day of his fitting with his carpal orthotic. It's not perfect. He's not walking normal. And there were some adjustments that we needed to do to get this carpal orthotic to be more functional. But this is better than nothing. And still today, where he's walking with a carpal orthotic and actually doing pretty well. Amputations are a common one that we see or practice. A lot of dogs, they do fine shortly after their amputation, but it's later in life that they struggle with their mobility. So often we will see these patients and we're teaching clients how to massage their back, how to build up their spinal extensors so that they can have better posture, how to stretch their biceps and triceps and keep their hip flexors lax. And how to help their dog transition to walking on three legs. So, how to circle, how to turn, how to transition on three legs. In this case is Claudia. She's a really cool case. She was actually born with a deformity in her leg and was a service dog and did fine in her younger years, but as she started to get older, she couldn't walk on her three legs anymore. So she was pulled around in a wagon and she was pulled off of being a service dog. She had a lot of compensation when I saw her, so she didn't like to walk these are a few steps that she went ahead and took for us to get video. But as you can see, her spine is hunched, her hip flexors are pretty tight, her pelvis was tilted up. Because often what dogs do when they have an amputation, so for example, a forelimb amputation, the remainder limb they'll go ahead and bring to the center and they'll bring a little back and they shift more weight onto that forelimb. So they'll get carpal hyperextension later on down the road. Claudia also had horrible arthritis. The hind limbs will come forward and they'll hunch their spine. So they're often set up for herniated discs in the future. These are her first steps in her prosthetic. So as you can see in just this video, her spine is able to be more flat and her pelvis is less hunched. With rehab, with amputations, if you can amputate below the elbow and below the knee, we have a pretty good chance of being able to put a prosthetic leg. That way they can bear weight evenly on all four legs. That way they can walk longer in their life. So this is Claudia just going through and learning some exercises, learning how to maneuver in her prosthetic. We have a solution for the inside of the house. So our patients aren't always in the prosthetics all day. So they have house slippers that they wear inside, and then they have prosthetics that they wear outside. And here she is back up to running and playing in the snow again. Intervertebral disc disease is, I would say, about half the patients that we see at our practice. You know, I've seen everything. I would say about half our patients are post-op hemi. The other half are going to be rehab conservatively and aren't going to go forth with surgery. We pretty much lay out the pros and cons of any procedure. So we don't make the decision for the client. We support them in whatever decision that they make and create a plan that's going to work for them. I've seen patients that, were completely paralyzed, so no motor, no deep pain, and we've gotten them walking again and running and jumping. The nervous system is absolutely amazing with its ability to regenerate and create new pathways to send signals up and down that spinal cord. So this is Pepper. Pepper was completely paralyzed. So she had no motor, she had no deep pain, she was urinary and fecal incontinent, and Mom was not going to go forth with surgery. So she reached out to us, and we actually did our best to get Pepper walking again. So we got her fitted with a wheelchair. We utilized the wheelchair just as an assistive device. So it's not one to do all the work for her. It just supports her so that she can take steps in the hind limb. We got her in toe ups so that way she wasn't dragging her back feet. And we started on physical therapy. And she made quite a bit of progress. So you can see in this video at the very beginning, she wasn't moving her legs. She was just dragging them in her wheelchair. And now she's learning to take steps. Eventually, we progressed her so that she was no longer in her wheelchair, and we were trying to teach her to walk independently from any assistive devices. So this is some of her exercises that she underwent with us. And you'll see towards the end of the video, we got her back up to running and jumping and playing again. So pretty good outcomes with intervertebral disc disease, even when they look pretty grim to begin with. Those are cases that I would say give them time and see if they will heal. I know they can look pretty bad right off the bat, but usually about a month later, we can get improvements with these patients with herniated discs. So this is what she has stairs that she has to climb at her house. So this is her learning how to maneuver on different surfaces and taking steps upwards. And she's able to go on walks again. And this, I would say, is about the course of, I think we worked on Pepper for about 4 or 5 months um, to get her back to, this essentially. So running around again. So Walter, I wanted to share this case because we learned a lot from Walter, and he's very unique in a lot of dedication from Dad and essentially the community supporting Walter through his progress. So when I first met, I'll just pause this real quick. When I first met Walter, he was running in the backyard and collapsed in all four legs. He was rushed to the ER, which had a neurologist on staff. An MRI was recommended to see what was going on. He was essentially paralyzed in all four legs. He couldn't lift his head and he lost his ability to bark. Dad cannot afford an MRI and he cannot afford surgery either. So euthanasia was recommended. Dad didn't feel comfortable euthanizing, so he took Walter home and he started doing research on trying to find what other options are there to help my dog. And that's when he found us. When I first met Walter, he was paralyzed on all four legs, no motor. He couldn't bark, he couldn't lift his head, and he was in a lot of pain. So we focused very heavily on pain management right off the bat, and then slowly progressed into proprioception. So a lot of our exercises with proprioception is tapping, tickling, vibrating, helping him sense where his legs are, just trying to wake up those nerve signals going up the spinal cord. This is Walter in one of his early sessions in the underwater treadmill. So in this video, you can see he cannot lift his head up. So we have the noodles to help hold his head out of the water. If you look at his back legs, they're just not moving. They're just standing there because he doesn't have motor back to his back legs yet. And Eric is gait patterning his front limbs. Where his injury was at was right at cervical thoracic, and cervical thoracic patients are very challenging because they have mixed signs. So he's upper motor neuron in the back legs, so he's able to stand up in the back legs, but because he's lower motor neuron in the front limbs, he cannot extend his elbows and fire his triceps to be able to stand up in his front limbs. The back legs, utilize extensor tone to help them walk, and so these patients will bring back function to their back legs before they bring back function to their front legs. So often, what it looks like is they go to stand up and their back legs elevate, but then their front legs can't. So then their chest drops down to the ground. So with our rehab, we are focused very heavily on trying to bring back the front legs, so that way they can keep up with the progression of the back legs. This is Walter a few weeks in. So in his back legs, you can see he's starting to bring back function and motor to them. So he is taking steps. It's not coordinated, but it will get there over time. But we're just so happy that he's able to move those back legs. He's able to wag his tail. And you can see he no longer needs the noodle because he can hold his head up on his own. And here's Walter a few months later. So, with our neurologic patients, it's very important that we take baby steps. I think people get in a rush to have their dog walk again, that they forget to teach them how to get up into a position where they can walk. And that is why I'll see patients where they'll be a year or two out from a hemilaminectomy and they're still dragging their hind limbs. And the reason why is because they were never taught all the baby steps on how to get up to a stand to walk again. So we have to teach our patients how to go from lateral to sternal, sternal to sit, sit to stand, and then it's walking. So this is Walter. He's learning to go from sternal to sit, and then from a sit back down to a sternal. So he's learning transitions before he's learning to walk. He is bringing back function to his upper limbs before his distal limbs. So that's how most neurologic patients improve is they bring back function to their shoulder muscles, then their elbows, and then their paws, the very last. Reason why is because it's further away from the brain. So sometimes they will want to walk. So they'll move their shoulders and move the elbows, but then they'll knuckle over in their feet and trip. So over time, he gets better. So we have the carpal wraps on. That way he doesn't knuckle in the front limbs as much. And he even has some toe ups to help him from knuckling. So why our practice? There's lots of rehab practices in Colorado, but why refer to our practice? We operate very differently. Our treatment plans are customized to the individual patient. So we don't have one protocol, say for like a certain disease, and we apply that to all the patients. Instead, our treatment plans are based off of our exam findings and the client's goals, and we look at the patient as a whole. So it's not just the injury; it's like what other compensatory issues are happening secondary to that issue or adding to that issue that we're addressing. We choose our treatment plans at each session. So often we go through and we're doing our exercises and we're watching the patient through the exercises and we're seeing where they're lacking, where they need help, and that will direct what we're going to work on for the next session. So everything's very customized to the individual patient. Our appointments are physician led. So there's lots of different ways practices operate. You have some practices where a doctor is just overseeing all the patients throughout the day. So there may be about like 50 or 60 patients coming through the practice in one day. And techs are performing all the treatments, and the doctor's just there kind of overseeing everything. There's other practices where there isn't a doctor, but instead it's a rehab certified technician that's running all the appointments. And then there's other practices where you have a patient bounce to one tech that does laser on the dog, then it bounced to another tech where that person's going to perform the hydrotherapy, and then goes to another tech where that person's going to do exercises. So kind of like an assembly line. There's nothing wrong with how anyone else practices. It's just over the years, I've worked through lots of different practices that have operated in those different ways. And I found the way that we practice, where they're just physician led, has led to better medicine, better outcomes, and faster recovery. So our doctors are in every appointment. They work with an assistant. So the assistant may be in there helping them perform laser while they're going through massaging or doing manual therapy on the dog, or the assistant may be performing the exercise while the doctor is watching the dog's movement. That way they can go ahead and analyze it and adjust our plan moving forward. We have longer appointment times, so it just takes time for patients to heal. So I don't want to rush any of our patients. Our evals are about 2 hours long. It allows us time to answer all the clients' questions, to create a plan together that meets their goals, to get started on treatments, and teach as much as possible in that session. Our follow up appointments are about an hour long, and that includes all treatments that we perform on the patient. A longer appointment times allows our doctors to perform whatever treatment is needed. So we don't price things separately. So we don't price out laser or ultrasound. It's just one price for the whole session. Whatever is needed, we go ahead and perform on that dog. We very much do take a team approach. So we round on our patients every morning, and every week we run as a whole team. We even do learning rounds where we'll review a disease or a condition or a new form of treatment to be able to apply it in our practice. This picture down here at the bottom, this is Luna. Luna is a interesting case. She was attacked by another dog, so she has a cervical thoracic myelopathy. She was paralyzed on all four legs, pretty painful, so we were very heavily focused on pain management at the beginning. We were able to bring back function to her back legs, but unfortunately, her front legs have acquired so much damage to the spinal cord there that they are not coming back. So we have to have a solution for Luna and think outside the box on how we're going to help her live with this um, new function that she has. So we got Luna in a wheelchair to help her with her front legs. She started off with a quad cart, so it had four wheels. Then she progressed to a cart with training wheels. And this is a cart with just her front wheels. But wheelchairs are only for dogs when they go out on walks outside. So a dog can't live in a wheelchair all day, every day, because they can't lie down. They can't always go into a sit. So Luna is one of the handful of patients that we have taught to walk upright like a human. That way, she has a solution to maneuvering around the house when she doesn't have her wheelchair. What to expect in our first appointment, we go over history, or we perform an orthopedic and soft tissue and neurologic exam. We'll discuss exam findings, a treatment plan, review medications and supplements. We'll create a home program and teach the client how to perform that home program. So it may be massage, it may be stretches, it may be range of motion or exercises. Taking history is very important. We usually start off with general concerns, ask about behavior, discuss pain. I would say dogs exhibit pain by changes in their behavior, or we even utilize the grimace scale. So their eyes being squinted, the ears held back, whiskers tight to the face to determine whether or not they're in pain. We ask about urinary and fecal incontinence, the environment. So do they have difficulty getting in and out of the car? Do they have difficulty going up and down the stairs? Do we need to do something about traction on the floor? We'll discuss medications and supplements and goals. And goals is really important because that helps direct our treatment moving forward, and our progression and how long they're going to be in rehab. So the dog that has the goal of just, hanging out on the couch and then going on a walk every day may graduate from rehab a whole lot sooner than the dog that has the goal of getting back to agility or getting back up to mountain biking with the owner. Treatments that we offer at our practice, we have laser therapy, acupuncture, pulse electromagnetic field therapy, electrotherapy, ultrasound therapy, exercises, manual therapy, and hot stone massages. Hot stone massages is another one of those things that they do in humans, and I was like, "Why are we not doing this in dogs?" And so I introduced hot stone massage into our practice, and everyone loves it, and especially the cats really like the hot stone massage. We also have diagnostic ultrasound. Our diagnostic ultrasound is for musculoskeletal injuries. So it's important when we have supraspinatus and biceps tendinopathies for us to get a baseline. That way we can track when that tendon is fully healed. Often with tendinopathies, the patient may not be limping anymore and they may look better, but they may still have a little bit of a tendinopathy left behind. We can graduate those patients from rehab, but they can easily re-injure it and end up back into rehab. So that's why it's important that we go ahead and ultrasound those patients. That way we know when they graduate from rehab that that tendon is fully healed. We have shockwave therapy, the vibration plate therapy too. I'll go ahead and talk about. The vibration plate therapy I really like for our neurologic patients. Our progression, very first thing is addressing pain. So we'll utilize the laser, the ultrasound, the electrotherapy, massage, cold and heat to modulate pain, even medications we can utilize in our sessions or at home to manage pain. After managing pain, it's often decreasing bruising, decreasing swelling, and then I work my way into improving mobility. So I start from the outside. I start with the soft tissue and the fascia and relaxing that. And then I work my way into the joints. So it may look like passive stretches. Then we progress into active stretches. And then we may work into passive range of motion and then progress into active range of motion. Following that, we may be working on proprioception if it's a neurologic patient, or if it's an orthopedic condition, we will be working on improving weight bearing and strength building, in which we'll use the underwater treadmills and balancing exercises to go ahead and strength build. Orthotics and prosthetics. We work with orthopeds to create custom orthotics and prosthetics. And I just wanted to go through and talk about a few cases that we see. This here is Marty. So Marty's in bilateral carpal orthotics for carpal hyperextension injuries. His is chronic and degenerative. So it wasn't the case of he jumped off of the back of the truck and then his wrist dropped to the ground. It just slowly happened over time. And mom cannot afford bilateral pan carpal arthrodesis surgery. So she came to us and we created a solution for him to be able to go on his walk still. Vinny has bilateral tarsal orthotics for tarsal hyperextension, and these are secondary to his hip dysplasia. So Vinny had a total hip replacement as a puppy that failed, and then he had a FHO after that. So he doesn't have the best hips. His hips are pretty much maintained in flexion. So by keeping his hips in flexion, he puts a lot of forward force on his ankles. And so his ankles were snapping in the opposite direction. So when I first met Vinny, he was in a ton of pain. I would actually categorize him as having allodynia. So normal touch was incredibly painful for him. He was a patient where if you just touch anywhere near his hip, he would try to bite you. And then after we got pain under control very heavily with amantadine and I'm trying to remember NSAIDs and gabapentin. So we utilize pain medications. Then we utilize all our different therapies to get his pain under control. He ended up becoming the most friendly dog, allowing us to touch and do whatever we needed to his hind limbs. And now he's in bilateral tarsal orthotics to stabilize his ankles. Sophie on the right is a cat with chronic prednisolone use. So her ligaments started to break down. So her wrist started to drop to the ground. So she can no longer walk. She couldn't even get in and out of her litter box to use the restroom. She was just so uncomfortable with her wrists dropped all the way down to the ground. So we worked with orthopeds to make custom little lightweight wraps for her wrists to keep them upright. I did want to touch base on cranial cruciate ligament injuries because this is the most common thing that we see in our practice. And there's a lot of different treatment options out there. When we see our CCL tears, it's very important that we categorize them into partial tears, or full tears with minuscule tears. That way, we can go ahead and lay out all the possibilities for the owner and what the likely prognosis is going down each route. When we see our patients, we don't push them in one direction or another. So we're not ones where we're like, you absolutely have to go forth with TPLO, and we're not others that, oh, do not do TPLO. We pretty much just lay out the pros and cons of each and let the client decide. And then our plan will go ahead and support whatever route that they're going down. I would say our partial CCL tears are great candidates for undergoing physical therapy alone or physical therapy with bracing. Bracing is really cool because it stabilizes the knee to be able to allow medial buttress to build up and be able to allow it to build up nice and focal and pretty strong. So if you think about, uh, you know, if you pulled out some dry spaghetti out of a container and all the fibers are stacked and running in the same direction, that whole wad of spaghetti is pretty hard to break. Versus if you have spaghetti just dropped on the counter and the fibers are going in every different direction, it's pretty easy to go ahead and break that bundle of spaghetti that's going in lots of different directions. So that's essentially what we're aiming for with the orthotic is to place the brace on and allow that medial buttress to build up where the fibers are all running in the same direction to be able to be nice and focal and at its strongest. We then work on building up the hamstrings and bringing back motor control to the hind limbs. That way, when that foot hits the ground, those muscles are already engaged and firing to stabilize the knee. With our full CCL tears, we have a couple different options. We can go down the brace route with physical therapy, or we can go down the route of surgery. I've had lots of success with full CCL tears and a stifle orthotic. They just take a little longer. So these patients are in an orthotic for, they could be anywhere from a little under a year to even over a year. Some patients, when you think of a 14, 15-year-old dog at end of life, they may not come out of the orthotic. They may have the orthotic for the rest of their life. So I just wanted to show you this patient. I have so many videos of patients in orthotics and undergoing physical therapy for CCL tears. She acquired a full CCL tear. Surgery was recommended, but owners, didn't feel comfortable with the TPLO surgery, so they went ahead and reached out to us for another option. When I saw her, she was like this. She was non-weight bearing for at least a month on that leg. She was a full CCL tear, and I was suspicious that she had a meniscal tear too, because she had a click. And this is her a couple of months into physical therapy, going on a stroll with mom and dad and the other dog. So she looks pretty good. And I've had success, when it comes to full CCL tears, meniscal tears, I've had a lot of success with them, rehabbing conservatively with a brace and physical therapy. I think what's happening in those cases is the meniscus is scarring down. But I would say prognosis is unknown if there's meniscal involvement. So we tend to lean a little more towards surgery because we will have the quicker fix with surgery, and we will have a little more of a guaranteed outcome than if we went the brace route. But I've done it many times. I've had patients with full CCL tear and meniscal tears get back up to running, jumping, and hiking again. Achilles tendinopathies are very common in our practice. The moment you have an Achilles tendinopathy, usually a brace is recommended, even if you went forth with surgery. Reason being is if you take a patient in a splint, so think of a splint as being offloading that tendon 100%, and then you take the splint off, let's say about 8 weeks after surgery, they pretty much go from 0% loading to 100% loading, and then they end up back at an Achilles tear. So orthotics come in handy, if they're going the surgery route. That way we can slowly load that tendon over time. And we're slowly articulating the ankle over time to be able to have a successful outcome. It could also play a role in the case where if the client is not going forth with surgery, or this isn't extensive enough of an injury to have surgery, so we need to heal it conservatively. So this is G. G is a pretty bad Achilles tendinopathy. Ankle, when she walks back the other way, you'll see her ankle drops completely to the ground. Dad declined surgery, so the orthopedic surgeon sent her our way. And our solution for G was an orthotic. So this is G at her fitting appointment in her orthotic. You can see she's walking pretty good, and the ankle's no longer dropped to the ground. So orthotics and prosthetics. If a patient is a good candidate for a brace or prosthetic, we will take measurements and create a mold of that leg in the initial appointment. We work with orthopedics to create a prescription of what the device will look like. So, what forces need to be corrected and what suspension issues that we're going to have with the dog's conformation. Orthopeds will manufacture the device, and then we go ahead and do a fitting appointment where we teach the client how to place the brace on and teach the dog how to maneuver in the device. And then we have follow up appointments where we're checking for proper fit, checking for sores if any adjustments are needed, and then getting them back up to full function. We also do wheelchair fittings. So I work with all the different companies. So our big ones are Handicap Pets and Eddie's Wheels. This is Walter in his wheelchair for the first time, learning to take steps forward. We get pretty creative with the wheelchairs. So he was one where he would knuckle on his front limbs. So we utilize resistant bands to prevent him from knuckling, but then also to help him swing through because he didn't quite have the swing yet. But wheelchairs, we don't view wheelchairs as a device to completely hold up the legs. I would view them more as of an assisted device to get a patient walking again. Laser therapy we offer at our practice. I won't dive too much into laser therapy, but I pretty much utilize laser therapy to regenerate nerves, decrease inflammation, and inhibit pain. We utilize the therapeutic ultrasound in our practice. I love the ultrasound. It decreases swelling in the area. So it's pretty cool to take a post-op TPLO where the knee is pretty swollen by the end of the session after laser and ultrasound. You hardly palpate any swelling in the knee. We also utilize it a lot to relax muscles. So, our medial luxating patellas may have pretty tight adductors and sartorius and vastus medialis. So, we'll have to go through and ultrasound those muscles to relax them and then focus on strength building the lateral muscles of the thighs, such as the biceps femoris and the hamstrings, to be able to pull that luxating patella more laterally. Electrotherapy, I love. I utilize electrotherapy to inhibit pain. So, with electrotherapy, a great example would be when you hit your elbow and your first reaction is to take your hand and rub your elbow. You're pretty much stimulating mechanoreceptors so that your brain is focusing on the sensation of touch rather than the sensation of pain. And that's how electrotherapy works. So we use electrotherapy a lot in our patients that come in with back pain or postoperative pain. We also utilize electrotherapy to stimulate nerves. So it's great for paralyzed patients or patients with neuropathies to try to send a signal up that nerve to the spinal cord to the brain. And then we can also utilize it to just contract a muscle to build up a specific muscle that we're aiming for. Acupuncture. We utilize acupuncture a lot for our neurologic conditions, our arthritis, patients with pain, and urinary and fecal incontinence. Right here in this picture, this cat has some points right over the LS region and lower back. These are great points for stimulating the urinary bladder. So often these cats that come in or dogs that come in that are urinary and fecal incontinent will have owners do lots of tickling to their lower back and tickling to their belly. We'll even do electrotherapy or electroacupuncture to that area to stimulate the nerves going down to the urinary bladder and kidneys to help with their incontinence. Pulse electromagnetic field therapy we use to promote healing and decrease pain. It can also speed up healing of bone fractures. Our shockwave therapy can be utilized to break up mineralization in tendons and also to bring in blood flow. So I love shockwave therapy for our tendinopathies, so biceps, supraspinatus tendinopathy, or Achilles tendinopathy. These chronic injuries, so I've seen cases come in where they've had a tendinopathy and they've been limping on their front limb for about a year, even up to 2 years. And the reason why is because the body essentially walled off that injury and it pretty much mineralized it. So you can see on x rays where that tendon is calcified. What shockwave therapy does is it goes in and it breaks up all that mineralization and it takes that tendinopathy and it pushes it into the acute phase so that the body can go ahead and heal itself. So it works very similar to PRP and stem cells, where it recruits growth factors to the area to speed up healing. Diagnostic ultrasound, I talked about earlier, just so that we can watch the progression of our injuries. We work a lot with our hands. So we utilize our hands to massage, to work out trigger points, to stretch muscles. We even do some mobilizations to a joint to either inhibit pain in that joint or to improve range of motion of that joint. So you could do mobilizations to get more flexion out of a joint or more extension. Therapeutic exercises, I would say, is the most fun part of our job. And it's the one where we get really creative with training our patients. So this is cricket. Cricket is learning how to do mountain climbers. So cricket acquired a CCL tear. It was pretty much close to a full CCL tear in that left hind limb. I had her in a brace, and we did 6 months of physical therapy, and eventually pulled her out of the brace. So she looks great on that side. The right knee started to go, so she is now in a brace on her right knee, undergoing physical therapy for that too. So with this exercise, she's learning to bring her left hind limb forward and tap the fit disc. To do this movement, she has to flex her knee. So she's getting stifle flexion. She has to fire her hamstrings in order to flex her stifle. And then in order to extend, she has to fire her quads and sartorius. So it's a great exercise for CCL tears. She is progressing to learning it on her right hind, and eventually she's going to be alternating. So she's going to go left, then right, then left, then right. So it's a lot of fun training patients on how to do these different exercises. The underwater treadmill, I love for patients that are post-op, for patients that need to lose weight, or patients that it's just uncomfortable to bear weight on land. An example would be elbow dysplasia and elbow arthritis. Those patients with a lot of land-based exercises, they may struggle with weight bearing or soreness after doing land-based exercises. So we'll go ahead and put them in the underwater treadmill and have them do different exercises on the underwater treadmill, such as weight shifting, three-leg stands, or high fives, or side steps, or circles. That way, they're strength building the muscles surrounding the elbow to stabilize the elbow without it being so uncomfortable because the water off weights them. And then we'll eventually get them to walking in the underwater treadmill. So get really creative with doggy water aerobics. And that is everything that I have. If you have any questions, feel free to email me at info@walkingpawsrehab.com.